Welcome you of curious minds to the American Academy of Optometry Foundation's clinical podcast series. In this episode, we will be discussing management of keratoconus with repeated use of corneal crosslinking. I'm Dr. Tom Quinn, and our guest expert for this episode is Dr. Suzanne Sherman, former director of optometric services, assistant professor in optometric sciences at Columbia University, Irvine Medical Center in New York City, who is now transitioning to a new position, and details to be announced soon. Welcome, Dr. Sherman.
Thank you, Tom, and thank you to the Academy for having me. I'm excited to be here, and this is going to be a lot of fun.
Well, we appreciate you being here because I know this is in your wheelhouse, this topic that we're about to discuss with corneal crosslinking and its effect on multiple uses and its effect on the keratoconus. So what did the authors of this paper want to explore?
I think they wanted to explore the efficacy and the safety of repeated crosslinking for patients who had significant progression of keratoconus after they had had one crosslinking procedure.
Okay, so let me ask you this. How did they define progression? And how often
It's a great question.
Go ahead and answer that first, then I have a follow-up.
It's a great question because I think you and me know in clinical practice, even though we have definitions of progression, not every physician follows that exactly. So in this paper, the diagnosis of progression was based on documented corneal topography, tomographic changes compared with previous measurements. And they defined it as a 1 diopter increase in the steepest radius of curvature of the anterior corneal surface, so Kmax, a decrease in the minimal pachymetry, so of 10 microns within 1 year, so the thinnest point getting 10 microns thinner within 1 year. And then they also did use other data to support their confirmation of progression, including visual acuity changes of 1 or more lines decreasing, changing in refraction of 0.5 diopters or more. And they did look at the difference maps and the changes of the magnitude of astigmatism. But the 1 diopter increase in Kmax and the decrease in Pachy was really the main thing.
Okay, any data on how often the progression occurs following a single use of corneal crosslinking?
So actually, there are a couple of different papers out there, and it's about 2 to 8%, they're saying. However, I think this paper is showing it, also having progression, but they're showing it coming a little further out in time after the crosslinking.
Okay.
It's important to note that this paper had a very small sample size. There were only 10 eyes being addressed. And as we know, as clinicians, every keratoconic patient is a little different, and the severity of their keratoconus and the rate of their progression is going to be different.
Yeah, boy, don't we know about that individuality? Are there certain risk factors that predispose some people to perhaps being someone we want to watch more closely for progression?
Yes. So in this paper, they found that I think 55% of these patients that progressed had atopic background, right? So we know that because in clinic, we see this, a patient comes in, they can't correct a 20/20, their vision they're complaining of halos and things like that. But you look at their face and they have eczema or they have severe allergies. So that goes in line with what we see. They also had some patients with Down syndrome who, even though we know rubbing our eyes is one of the only things we know for sure that progresses the condition, we don't have that much control over how much they rub their eyes. A very high Kmax starting with, and a younger age. I have a distinct memory of one of my absolute first patients at Columbia who was I think 11-year-old with a Kmax of 90, and they just skyrocket. So those are the people we're really watching the closest.
Okay, but what else did the authors find in the study?
So, I personally feel like they confirmed a lot of things we already knew, right? They confirmed that a young patient is at higher risk, high Kmax is at higher risk. Patients who have atopy are going to be at a higher risk. They found that, things like from the time of first diagnosis of keratoconus to their first cross-linking, there was a widespread of around, 2 years or so that patients would have this done. And they found that there was a range between whether you had cross-linking the first time and then you needed it again the second time. And that range could be anywhere from 3 to 4 or 5 years or 2 to 4 years. So it really was between a large span of time, in my opinion, of needing cross-linking again.
Well, did they find the second application of corneal cross-linking to be effective and safe?
So it's an interesting question, right? We know that the first application, the main risk factor, I think, is corneal haze, and then we see it decrease, right? So what they found that, number one, visual acuity didn't change at all. Number two, they found that no one developed haze after the second corneal cross-linking. And in their paper, they said there were no additional risk factors or complications.
Okay.
Again, small number of eyes.
Right.
And I think with surgery, there's always risk. And corneal haze, if I've seen a lot of patients that get cross-linking, the ones who do get it and it doesn't get better, that's something to definitely consider.
So, Suzanne, after reading this paper, are there any changes you will make or recommend we make in our approach to managing patients who are keratoconic and show progression after corneal cross-linking?
I don't think there's dramatic changes I would make. I think we have to be very careful to watch these patients closely, especially the ones who have high risk. Mm-hmm. However, we already were treating patients a second time if they needed it. And I think that I wouldn't be hesitant to refer someone for a evaluation for it. It's something we have at not at our fingertips everywhere, but it's something that is accessible now. So why would we hesitate to at least have them talk about it?
Great. Dr. Suzanne Sherman, thank you so much for sharing your experience and expertise on this topic. And thank you all for listening.
Thank you for having me.